I'd like to talk about how to make a capsulorhexis. The size and the position of the capsulorhexis is very important for the stable intraocular lens fixation, and also it is very important for the precise post-operative refraction. And also it may prevent the lens epithelial proliferation. So if you implant a 6 mm optic intraocular lens, the ideal size of the capsulorhexis should be 5.5. We used to use the markers to make the 5.5 using the ink, but the mark made by the ink sometimes hinder the procedure during the phacoemulsification. So I developed a new marker. I made a special treatment on the surface of the edge of the marker, and this is new markers. And for the capsulorhexis, I use a very fine, very thin Utrata capsulorhexis. It can go through 1.8 small incision, and it is quite easy to manipulate because it's a conventional design of the capsulorhexis forceps. And this is a new forceps which I put this marker at the end of the instrument. So you can mark the ideal size, and you can perform the capsulorhexis immediately. This is a magic marker. You can clearly see the mark on the cornea, but once it is wet, it disappears. So it never hinders the visibility of the anterior chamber during the phacoemulsification. Mark the cornea, and then you can follow the capsulorhexis along this mark. It's quite easy to make an ideal size and ideal position of the capsulorhexis. At the end of the surgery, the capsulorhexis edge should be uniformly on the optic. So first, we perform the capsulorhexis. I'll ask the patient to look at the center of 3 lights. As I use Lumera 700, there are 3 lights reflections. And I recommend don't to wet the cornea until you make the mark. If the cornea is wet, you cannot clearly see the mark. And also it is important to dry the instrument. Then after making the incision, fill up the chamber with this passive type of viscoelastic material. It can protect the corneal endothelium during the phacoemulsification, and it is not easy to come out through the incision. So this passive viscoelastic material, such as the viscoat, is quite useful to perform the capsulorhexis. And the important point is to always to keep the positive pressure in the anterior chamber. If the pressure in the anterior chamber is less, the tear is easy to go to the equator. I usually use the 3-step technique. First step, second step, and 3-step. By 3-step, I make a round capsulorhexis. When you introduce the forceps into the anterior chamber and when you open the blade, you should always keep the blades horizontally. If you tilt the blade, the viscoelastic material OVD will come out through the incision and the pressure will be decreased, and the tear is easy to go to the equator. So if you open the blade, it should be always horizontal. First, you puncture the center of the capsule with the right hand side of the blade and cut the radius, and then grasp, and then make 2, 3 steps. And then degrasp again, and 1, 2, 3, and degrasp again, 1, 2, 3, and finish. So the important point is that you should not make any notches when you continue to the next step. So the marker is quite useful to make the good guide for the lexis. Press it, and you will clearly see the mark on the cornea. Make incision, inject viscoat, fill up the chamber with sufficient amount of viscoat so that some viscoat may come out through the incision. Puncture at the center, cut the radius, 1, 2, regrasp, and 3. In 3 steps, you can make the capsulorhexis. If the patient cannot gauge, and this is the nystagmus patient, the eye movement, the eye moves, so I may use a nucleus sustainer on the sideboard to fix the eyeball, puncture, cut, grasp, second, and third. So I can control the eye position with the second instrument. In this case, I stain the capsule with a green dye, so you'll be able to see puncture, cut, grasp, tear, and tear in 3 steps, and the fragment should be taken away from the anterior chamber. When you puncture the capsule, if you see the fold in the anterior capsule, this is a sign of the weak zonude. You should be careful in such a case. Carefully and slowly perform the capsulorhexis. Sometimes the lens may be subluxated in such a case. So in this way, with a good microscope and a good head position, we can get a good reflex, and the capsulorhexis itself is not quite difficult if you have a good marker and a good forceps. And the key point is to use a dispersive viscoelastic material filling up the chamber. But the challenge is an intumescent cataract, white cataract, with sometimes in the atopic patient or the diabetic patient, we have such a white cataract. In those cases, I give the hyperosmotic agent 90 minutes, 1 hour and a half hours before surgery. I give the glycerin or mannitol, and then decrease the pressure. I always stain the capsule. Unfortunately, we don't have the blue dye in Japan. We use a green dye in the cyanin green, but in the cyanin green can stain the capsule only faintly. So I'll mix this dye to the cohesive viscoelastic material such as the Provisc and make it like a paint, and paint on the lens surface. In the case of the intumescent cataract, there is so much pressure in the lens. So once you puncture the capsule, the tear will go to the equator and may go to the posterior capsule, and the nucleus may drop. So I always give a hyperosmotic agent to decrease the vitreous pressure as well as the intraventricular pressure. Then I fill up the chamber with cohesive Provisc, because cohesive OVD is quite easy to remove. And then I apply visco ICG in the cyanin green dissolved in the Provisc, is painted on the lens surface, and then wash out the chamber. Then osmotic pressure, such as helium 5 viscoelastic material, is filled in the anterior chamber, and fill more to make the lens surface concave. Very high pressure is a key for success in such an intumescent cataract. Then make a small capsulorhexis first and aspirate the liquefied cortex, and then continue to the normal size of the rhexis. Fill up the chamber with Provisc, cohesive viscoelastic material, and in the cyanin green is painted on the lens surface. Now the Provisc is protecting the corneal endothelium. When I wash out the chamber, only the lens surface is stained green. Then helium 5 is applied, and the puncture carefully, making a small puncture, then liquefied cortex will coming out, liquid. Then carefully making a very, very small capsulorhexis. It can be 1 millimeter or 2 millimeter. Very small capsulorhexis should be made. Then through this rhexis, you can aspirate the liquefied cortex. Once the liquefied cortex is aspirated, there's no pressure, no intraventricular pressure. So the following capsulorhexis is quite easy. Making a small notch with a capsule scissors and grasp with the retractor forceps. and carefully enlarge to make the second Rexis. Unfortunately, in this case, I didn't have the capsule Rexis marker. So in this case, the capsule Rexis was a little bit smaller than the ideal size, maybe 5 millimeter. But anyway, once the liquefied cortex is removed, this second Rexis can be performed quite safely. Then, after removing the cataract, under the cohesive viscoelastic material, such as Probix, lens is implanted. But I noticed that the capsule Rexis is a bit smaller. If the zonule is weak, in this case, then capsular phimosis may happen. The capsule Rexis window will become smaller and smaller if the zonule is weak. So in such a case, I need to implant the capsular tension ring. And in this case, I decided to enlarge the Rexis under the cohesive viscoelastic material before I remove by IA. So in this way, in case with an intumescent cataract, important point is to decrease the interlenticular pressure and make a small capsule Rexis, aspirate the cortex, and then multiple capsule Rexis make such a complicated cases easy. Thank you very much.